I'm Dr. Terry Jo Bichell. I am a neuroscientist. I also am the mom of a 22-year-old son with Angelman Syndrome. And I'm very happy to be presenting to you Angelman Updates, which is a joint production by both Foundation for Angelman Syndrome Therapeutics and the Angelman Syndrome Foundation. We are interviewing scientists and clinicians who are on the cutting edge in the Angelman field. And I have to say that I am really happy to be today interviewing Dr. Art Beaudet. I am basically a fangirl for Dr. Beaudet, and I am just really excited to ask him a few questions today in the short amount of time we have. So, Dr. Beaudet, can you introduce yourself?
Yeah, I'm Art Beaudet. I've been in academia most of my career, but now I'm in a small company that I'm starting. I trained in pediatrics and genetics, and I became interested in a phenomenon we encountered called uniparental disomy in the 80s, where we encountered a girl who had inherited 2 copies of chromosome 7 from her mother and no copy from her father. And this was called uniparental disomy. And she had cystic fibrosis with 2 copies of the mutation from her mother. And she also had short stature, which is, we now know, caused by the fact that if you have 2 copies of the chromosome 7 from your mother, you have short stature. It got me interested in what's called genomic imprinting, where at the time there was relatively little clinical interest in this process. But it has to do with genes like the Angelman gene, which behave differently on the copy that you inherit from your mother and the copy you inherit from your father. So becoming interested in genomic imprinting, the main disorders that were out there that were well known and definitely involving genomic imprinting was Prader-Willi syndrome and Angelman syndrome.
Wait, how did anybody know at that point that they involved imprinting back in that day?
I can't remember the dates of when things happened one relative to the other, but the knowledge that there was imprinting going on is there was a deletion that you could find on chromosome 15. And with higher resolution banding, people were beginning to identify this deletion. Then they often did DNA markers to try to determine if the deletion was on the chromosome inherited from the mother or was the chromosome inherited from the father. And what they learned fairly early on was that if the deletion was inherited from the mother, you had Angelman syndrome. And if the same identical deletion is inherited from the father, you had Prader-Willi syndrome. When I say inherited, the deletion is not really inherited, but it's de novo on the chromosome that came from the father, or it's de novo on the chromosome that came from the mother. So that was very clear cut. I mean, there was no violation of that rule. If the deletion came from the mother's chromosome, you had Angelman. If the deletion came from the father's chromosome, you had Prader-Willi. I started out kind of equally interested in both disorders, and actually for a while was going pretty regularly to all the Prader-Willi and the Angelman meetings. Our lab got involved in trying to find the Angelman gene, and eventually we and a competing lab came to the awareness that the gene that was mutated in Angelman syndrome was UBE3A. Sometimes back then it was spoken of by the protein name of E6AP.
So I just want to reiterate what you just said. Your lab and another lab at the same time, but your lab found the gene for Angelman syndrome. This was in what year?
Oh,
I think it was 1996.
That sounds about right, but I'd have to go back. I think that we actually had identified this gene as being in the Prader-Willi-Angelman region. And 3 or 4 years before. And so we were a little slow to figure it out, actually. And then I was going more and more to Angelman work and Angelman meetings, preferentially compared to Prader-Willi. And Terry Jo and I met in Finland many years ago, close to the time your son was born.
Mm-hmm.
And there was some other things going on about genomic imprinting and DNA methylation and how you might alter things. And partly on a conversation with Huda Zogby, who is a colleague I've worked with a lot, we began to talk about the possibility of turning on the father's copy of the gene as a way to treat Angelman syndrome. And many years went by. We tried some treatments with folic acid, which didn't do anything. And then eventually there was a report from Ben Philpott's lab that certain drugs could activate the paternal copy of the gene. And then an outstanding student and postdoc in my lab took this information, and we also, the community knew there was a sense and an antisense RNA being transcribed in opposite directions. And it turns out when they collide, you don't make anything useful. So Ms. Student Lin-Yan Meng, first she introduced a stop signal in the region of the antisense and showed that if you did that, the father's copy of the sense now was expressed. And for all that's going to go on about treatment, it's very important that it seems like the father's copy is expressed and controlled precisely as it is for the maternal copy. So when you turn on the father's copy, it's turned on in all the right places at all the right levels with all the right isoforms. So this is a very fortuitous and favorable situation for Angelman syndrome.
Hold on, I got to stop you again. Because when I met you in Finland in the year 2000, you already thought Angelman syndrome was curable. You thought, and was that because at that point already you were thinking about how in a strange way it was a lucky disease because there was a paternal copy sitting there ready to do something if we could only get it to turn on?
Yeah, that part was certainly a unique aspect, and it intrigued me that this fit with imprinting, that you could have certain things where you could use alternative copies of the gene. The other thing, though, that was important is that Angelman children at birth and Angelman mice at birth are relatively normal. I mean, you do a brain imaging study on an infant with Angelman, it'll come back relatively normal. And while you can find certain feeding difficulties in the newborn period, many children used to go undiagnosed for years. So you have to have, to come up with a cure, the patient has to be in reasonably salvageable condition after birth. Obviously, if you're born with the brain only half the weight that it should be and not structurally properly formed, I don't think there's any way of putting that back together in a way. So I think the fact that the Angelman children were relatively healthy at birth and neurologically fairly normal, along with the fact that there was an alternative gene that you might be able to turn on, I thought it was very, very fascinating. Then this same student, at one of her committee meetings, somebody who was an RNA expert made the comment that what was then ISIS was a company that was using oligonucleotides to turn things on and off. And we discussed the possibility that we might use oligos to turn off the antisense in the father, and then his sense transcript would lead to expression. And So I didn't have any contacts at ISIS. We got involved, we started talking. I don't think ISIS knew anything about Angelman when I started talking to them. And they said, well, they could make a whole bunch of oligos, and they did. They sent them to a person in my lab who tested all of them and found that indeed you could, in the mouse, you could turn on the father's copy of UBE3A with antisense oligos.
When you found that, did you go out and drink champagne? Did you jump up on top of the lab bench? What did you all do?
I don't recall all that much. I think that you tend to learn these things by increments, that there are certain stages in the work when you think it's probably going to go one way. And then it gets a little more confident, a little more confident, a little more confident. Sometimes there are times where you identify a gene, like the day you identify the Angelman gene, you can identify it's one event, it happens on a day, and you can celebrate it and you can know where you are. This, I think we kind of oozed into the understanding over a period of weeks. And so I don't really have that clear, but I did, I think, believe at that point that Angelman would be treatable by this approach, because the company ISIS already was treating spinal muscular atrophy with the oligonucleotide, which provided precedent that it could be safe and so on.
So what I need to ask you now and sort of jump, that was only a few years ago. That was 5 years ago, something like that. But now
it wasn't all that long ago.
No, and we already have 2 clinical trials going and another one coming up. And that was all springing from that work, which is
when I think back about what impact your work has, I think that collaborative study with ISIS, where we showed you could use oligos to turn on the father's copy of the gene, that is likely going to translate into, from what clues and hints we hear, I think maybe some dramatic benefits. For a long time, people have tried to treat children with Fragile X syndrome. And it's been a pretty unsuccessful venture by and large. And they're always looking for minuscule kinds of benefits. And it's always been my view that if you treat Angelman's patients and they don't talk, the treatment's not any good. If they talk, it's going to be easy. You can just record them and say, this patient didn't used to talk and now they talk. And I don't know how many words they might have and so on, but it sounds like that's going to prove to be true.
But Dr. Beaudet, wait a minute. So if a person is already 15 years old, or I don't know, 12 years old, even whatever, 22 years old, like my son, and even if all the neurons, suddenly the paternal UBE3A is turned on and the neurons can now work, I mean, they still have to connect. They still have to form network somehow.
Yeah, we really don't know. I think everybody would start out with the idea that if the treatment is going to work, it's going to be best to do it very early in life, maybe within the first year of life even. And maybe even people are already talking about before birth. But you would think that patients who are 22 would have less room for benefit. But, maybe we don't know. In the spinal muscular atrophy story, there is some adult onset disease there where it was thought that these patients wouldn't benefit, but they are indeed benefiting. And we know that if you have a crossed eye and you don't use it through your age 2 or 3, you'll lose the vision in that eye with a process called amblyopia. If you force the crossed eye to be used, then you will preserve the vision in that eye. So that's a very clear example that you can't come back and fix amblyopia at 10 years of age or 15 years of age or 20 years of age. There's a developmental window where the brain has to learn how to see through this eye, and you have to catch it at that time. But we don't know what's keeping Angelman children from speaking. They clearly show they have information and they want to communicate and they can use devices. And I don't know, I haven't seen a single patient so far, but the stories that are being reported, which sound legitimate, are that some of the patients who've been in the very first clinical trials have used words when they had never used words before. And I think some of them were a little bit on the older side even. So I don't know, you know, I wouldn't say it's out of the question. You could take a 30-year-old Angelman patient who's never spoken a word and have them use some words. That would be, and that will be a real impactful series of events for the lay public to see. I think we've seen now a few pictures of first dogs and then humans who couldn't see, who had gene therapy for their eyes, and now they could see more and they could get around and so on. But taking a therapy and taking a patient who has no speech and allowing them to talk, it's every bit as impressive as going from not being able to see to being able to see. And these kinds of, although somewhat rare examples, are really spectacular and of great benefit, obviously, to the individual families and patients.
So is it true that you're retired?
So I closed down my Angelman work and closed my academic research lab. I'm now sitting in a lab in a company called Luna Genetics, where we're trying to develop a test that would allow for a detection of various kinds of chromosome abnormalities in all women without any amnio or CBS procedures. So a non-invasive test. Some people may be aware there's a non-invasive test now that's offered to women, but it's mostly for things like Down syndrome and other trisomies. And it doesn't detect deletions like Angelman and Prader-Willi. So we're trying to modify this test to use very rare fetal cells in the mother's blood, and then we can get much more detailed information. And it would be a test that I think will be offered to all women for the next 500 years, that there are all these de novo events, and if you want to know about them, you have to test after conception. And that we could detect, initially the test we're hoping to launch in a couple of months would detect all the deletion cases of Angelman and Prader-Willi. In the case of Angelman and Prader-Willi, there are other formats that require different lab approaches, but I think it would be possible very soon that virtually all deletion cases could be diagnosed. And we're talking about 8 to 10 weeks of gestation, earlier than amniocentesis, which is typically done in 16 weeks of gestation. So
And
I think
it's a blood test.
Yeah, and it's a blood test. It's a blood test, but you can get information that is basically equivalent to what you get with an amnio or CBS.
So I'm glad to hear you're not really retired. It would be kind of scary and hard to believe if you were. But I just want to ask you a couple things. So through the years, so you found the gene for Angelman syndrome, you pioneered at least one treatment that might actually make a revolutionary change. So I have two questions left. One is, what other treatments do you think have the biggest potential for Angelman syndrome, possibly? And number two, does your wife think you're crazy? Has she been following this with interest, or did she think?
Yes, she puts up with my various manias, I guess. I think that it seems to me one variation on this theme there's been a lot of talk about CRISPR as a new kind of genetic manipulation. And there's already people working using CRISPR in Angelman mice to try to turn the father's copy of the gene on with once per lifetime treatment, instead of month after month having to continue treatment. And I do think the CRISPR methodology is really ideal for many applications of trying to treat genetic diseases, particularly because you can go in and correct the defect when it's a small defect. When there's a small mutation, you can go in and actually correct it. So you really have put everything back the way nature intended. I would point out, though, there's a downside to the Angelman therapy, which is that the vast majority of the patients have deletions, and these deletions remove 10 to 15 other genes. And so the child who's treated will be corrected for UBE3A, but they will still have half normal levels of a number of other genes. It's likely that that is going to prevent them from being a cure to being exactly, let's say, the kind of IQ that they might have had otherwise. So the therapy that's being discussed actually can give a little more complete correction in cases of point mutations and imprinting defects and other kinds of formats. So I think it is important to keep in mind that for most patients, the Angelman is caused not by a mutation in the UBE3A gene. It's caused by a big deletion that takes out 10 or 15 genes. And we aren't going to be correcting the other 10 or 15 genes. So we can't expect a perfect result, but we can expect, something that's way more dramatic than we almost ever see in treatments of children with neurologic disorders.
Well, that is an amazing career that you have had and are still having, to be able to figure out what causes a disease and see it all the way through to a potential cure. And it's just absolutely amazing. And you didn't even talk about all the other things you developed, like microarray, genetic testing, all the other disorders that you work with, all of the students and postdocs that you've trained that have gone on to also work in Angelman syndrome and other neurodevelopmental disorders. Your impact on this field is the biggest.
I've been fortunate to be born at a time when the world knew very little about, almost nothing about genetics, at least as we know it today. And while I was in high school, Watson and Crick described the publication of what the structure of DNA might be. I actually didn't realize that until I was a freshman in college when I read that paper, and the idea of how DNA could replicate and so on was so fascinating for everyone. And I just felt this is what I want to do with my life, is work in this area. And at that time, there was no genetic code. There was a hypothesis that there might be a genetic code. And when I started seeing patients shortly after finishing training in pediatrics and genetics, we had most of our patients, we didn't have any understanding of what was going on. And those, frequently when we did, we didn't know the molecular details, but there were just many, many patients where they had some genetic condition, maybe because the family had 3 identically affected children, but we couldn't treat it, we couldn't give it a specific name. So it's been, and now to have, we're sequencing whole genomes all the time, and we're sequencing the genome of single fetal cells here, many at a time, 100, 200 at a time.
Wow. So here's my very last question, and that is just, if you could say one thing to the families, maybe about how they've impacted you, or what knowing the families has done for your thinking over the years, or any advice that you might want to give the families of young children with Angelman syndrome right now?
Well, I've been spent years doing pediatric genetics and often making diagnoses in the first day of life to the first 2 or 3 or 4 years of life, where the news for the family is tragic. These are very, very disabling disorders, and there's usually no treatment. And it's extremely burdensome and difficult for the families, and many families end up in divorce over such things and so on. So I've been very impressed by the huge burden to individuals and families and society to these disorders. And I'm all for treatment, and I'm excited about treatment. And I think for Angelman syndrome, there is more opportunity than for most of the other childhood neurological diseases. So it seems like maybe if you're going to have a child with a disability like this, Angelman might be a more hopeful situation. There is going to be the opportunity to diagnose things very early for many. I think that it won't be long, and if it's genetic, we can diagnose it in the first trimester with a blood sample, period, anything.
Wow. Well, I gotta say, you're always on the cutting edge. I really, really appreciate all the work that you've done all these years, and I appreciate knowing that you're still working on all these problems. So thank
And
you
I'm
so
looking
much.
forward to, there's going to be meetings this summer that will give us hopefully some update on how these trials are going.
That will be great. So thank you so much, and
Okay, thank you.
bye-bye.
Pleasure. I'm going to stop.